if you type on Google myomas or fibroids, you're going to find 19,700,000 entries on fibroids, which is the highest number that you can find for a female pathology. So this was just like 2 days ago. You see it here, it's 19,700,000 entries about fibroids. So theoretically, the organizers asked us to speak for like an hour and a half, and I have to cover maybe like in 15 minutes around 19,700,000 entry, which is not feasible. So what I'm going to do is to be more simple and to give you some like pinpointed information. And if you have any question, you can keep it till the end to answer you. So the outline of my presentation will be for the next 10 to 15 minutes. It's a definition. What are fibroids? What are the symptoms that they cause? How to diagnose them? How do we treat them quickly? Because Dr. Koitang will be doing a part of the treatment, so I'm not going to go with overlapping her presentation. Then we are going to speak quickly about fibroids and pregnancy. Do we have to get pregnant when we have a fibroid? Or do we have to remove them before? Do we have to keep them? What they can complicate the pregnancy? And finally, if we have a fibroid in the menopausal age, what to do? Do we have like to get worried because of cancers? Can we take hormones? These are the questions that we will have. And then in the conclusion. So to start with definition, we call them fibroids or myomas or leiomyomas, but also the lay word will be tumors. Many patients come to me, I have a tumor. In medicine, tumor is like a broader word, but for us, we say it's fibroids or myoma, and they are abnormal growth, so she shouldn't be there. They are abnormal growth from the muscle of the womb. Okay, and theoretically, they are not cancer. So we know that they are not cancer, but we are not very sure before doing a surgery that they are not cancer. And this is the most common pelvic tumor. It's around 12 to 59% incidence. So if we'd like check publication, it goes from 12 to 59 depending on ethnicity. It's going to be more frequent with age. And in the late 40s, we expect like 75% of women will have at least a fibroid. And if we go with 50s and 60s and 70s, sometimes you can have some publications over 95% of fibroids. So we think it's like a normal aging of the uterus to have fibroids. Now the risk factors, so which woman is like at a higher risk to get them? We will have like some risk factors that we know and some that we still are under investigating them. So I'm going to just cite the one that we know for the moment. First is the number of pregnancies. So the more we have pregnancy, the less we will have fibroids. So if a patient has 5 kids, it's better than to have 1 because you will have less fibroids. The earlier the menses start, and the more the patient will have fibroids. So if they start at 9, it's worse than if they start at 12 or 13 or 14. If they're using long-acting progesterone for birth control, it is better because we will have less incidence of, so it's a protective factor. Obesity is the opposite, it's a risk factor. So with obesity, we have more fibroids. Significant consumption of red meat. So the more, mainly the cow's meat, it's also linked with red meat to a higher number of fibroids and a higher incidence of fibroids. Vitamin A, it reduces the risk of getting a fibroid. Alcohol, beer increases the risk. Genetics also, we have families of fibroids. So the mom and the daughters will have fibroids. And finally, the black race. So dark-skinned patients and dark-skinned women at higher risk to get multiple and bigger fibroids than the white race. Well, the location, I'm going to show you just 3 locations. We know that we have more others like in the cervix or in the broad ligament, but just like as the big picture is that we have some fibroids inside the uterus, so it's in the cavity of the uterus. We call them submucous, they're just below the mucosa of the uterus, the inner layer. Or we can have intramural, so they're in the wall of the uterus itself, or they can be just on the outer side of the uterus, which is called a subserosal fibroid. We can have, as I told you, other locations, but mainly these are the ones that we target when we want to explain for the patient and when do we want to take our decision if we remove them and how to remove them. The symptoms that we can have in general are nothing. So most patients will come to us with a fibroid, but we've discovered on ultrasound or another imaging or just on exam. In general, fibroids don't have symptoms. But if they're symptomatic, you are going to see that the fibroids is in general in the uterus, and the uterus has like organs around it. It has the bladder in front, and the bladder which is here, and the rectum, which is, or the colon, the bowel, which is back. So some of the symptoms will come from the uterus itself, but some will come by compression of surrounding structures. So the fibroids that can cause first heavy bleeding because they're having more blood supply, and then it's going to have a heavier menses every month. Or they can press on the bladder, so we can have frequent urination. I just saw a patient today in the clinic. She goes to the toilet every 30 minutes. She can't hold, even all the night, she wakes up every 30 minutes to go to the toilet. She has a big fibroid, it's pressing her bladder. Also, we can have a pressure on the rectum, which can give us constipation, so the bowel movements will be spaced. But also, we can have a difficulty to get pregnant, so infertility, because they can be inside the cavity, so they can have a negative effect on the pregnancy, or in the wall sometimes it can affect the pregnancy. The ones that are outside, these ones are lesser degree causing infertility. And finally, we can have pain or pressure wherever the fibroid is. If it's a big fibroid, whether it's inside, outside, in the wall, it can have pain. And that's why we're discussing pain today. So it's a pelvic pain session. So fibroids, they also cause pain. And the way they do it is different. So the fibroid itself is not painful. Even if you have a big one, it's not painful. The pain comes from the weight. So the weight is going to press on the wall, and then the wall will be painful. But also, as we said before, it's going to press on the surrounding organs. If it presses on the ureter, we're going to have like kidney pain. If it presses on the bladder, we can have pain. On the bowel, we can have pain. Also, we are going to have sometimes an outgrowth of the blood supply. So the vessels are not enough to give oxygen to the fibroid. So it's going to have like a heart attack, but it's a myoma attack if you want. So it's going to have like less oxygen, so the fibroid will like die, and it's going to be painful. Also, we can have pain with the clots that come from the heavy bleeding. So once the clot is going to go out, because the fibroid is bleeding, so the patient is going to have like cramps to just push the clot outside. And finally, with intercourse, because we can have like a mechanical action during the intercourse, that the uterus is moving, and then it can cause a painful intercourse. So how do we diagnose these tumors or fibroids or myomas? The first is history. So as you saw before, we have symptoms. We ask the patient, do you have bleeding? Do you have constipation? Do you have frequent PP? Do you have, were you able to get pregnant easily or not? So all these can give us a clue about if this patient is having or not fibroids. Also, we're going to have a physical exam that we do in the clinic, where we can touch them with either palpating the abdomen or to do the pelvic examination. Lab tests won't help us a lot, so we'll not do like any blood test that will help for the fibroids. Pelvic ultrasound, also you can see them on the pelvic ultrasound. They can be scattered in the uterus, but also MRI can give us sometimes a better assessment of the number, size, and location of the tumors or of the fibroids. And then we have to choose the treatment, which will depend on many parameters. So now you'll see that it's a case by case and cannot give you like one treatment fits all. So you'll see that depending on the symptoms, so if the patient is asymptomatic, theoretically we do nothing. Just she can live with the fibroids, we can see if they grow or not. Then about the age, so the younger the patients, the more we are going to have alternative techniques to hysterectomy. Tamisha will discuss this. Then, depending on the desire of pregnancy, so if the patient wants to have kids after, definitely we can't do a hysterectomy. We have to do other ways. If she's done with her kids or she's a little bit older, we can go for a hysterectomy. Then the size, number of location of fibroids will dictate how we will do the surgery. Will we do it open surgery, laparoscopic, robotic, vaginal, hysteroscopic? All these will be just defined by what we know as size, number, and location for the fibroids. Definitely, we have to always assess the risks and benefits of each treatment to be able to take the decision with the patient about what she wants to have. First of all, the medical treatment, we can have pills like birth control, antagonist, that we can, tranexamic acid for the bleeding, patches, which are mainly hormone, vaginal rings that also are hormonal treatment, injections, like we can have depot or whatever every 3 months. Also, we can have implants with some hormones inside, and finally, we can have loops to decrease the pain, but also sometimes to decrease the blood loss every month. We can have a surgical treatment. Even if you have the fibroids and you want to stop bleeding, sometimes you just have to remove the inner layer of the uterus, which will be what we call the endometrial ablation by hysteroscopy. But also we can just remove the fibroid. It's called myomectomy. And this is done by hysteroscopy, laparoscopy, robotic, or open, depends on the size of the uterus. And we can have hysterectomy, which can be done vaginally, laparoscopically, robotically, or open, also depending on the size, location, and number of the fibroids. Other than medical and treatment, we have like semi-medical or semi-surgical treatments, which can be first the uterine artery embolization, where we are going to use some glue inside or like beads inside the vessel, which is going to supply the fibroid. So we can have like an ischemia of the fibroid, so the fibroid will start to shrink. We can have the focused ultrasound surgery, where we are going to send a boom of ultrasound pulses to a beam, of ultrasound pulses on the fibroid. So it's going to shiver, and then all the surrounding blood supply will decrease, and then the fibroid will decrease with time. Also, we can use radiofrequency, which is like the ultrasound, but it's a different way. We can do it laparoscopically or transcutaneously. And finally, cryomyolysis, where we use the cold temperature to be able to induce a necrosis in the muscle, in the fibroid. Well, the decision to use each type of medication, as I told you before, depends on the invasiveness. If you don't want an invasive procedure, no surgery, no UAE, you can go for medication. It depends also on the desire of pregnancy, and finally on the time to menopause, because the more the patient is near to menopause, 45, 55, the more they are prone to take decisions for hysterectomy, because this is the solution with the least recurrence of the fibroids. Well, in pregnancy, we can discuss if we want to do a myomectomy before the pregnancy. It depends on the obstetrical history. So if the patient has lost many pregnancies, the only explanation of infertility is just this fibroid, so we might discuss to remove it, especially for the submucous and the intramural one. Subserosa, in general, we don't do anything for pregnancy. Then during pregnancy, you can have many complications linked to fibroids, as you see them here, from like giving birth earlier to having bleeding to go to a cesarean section because the fibroids are bigger and then they're just blocking the pelvis, so the baby can't go out. So you see that we can have this discussion always with the obstetrician to see if we do the myomectomy before or not. And finally, also during delivery, we can sometimes, before we weren't doing any myomectomy, now there's some studies showing that we can do it if the fibroids are small and not like numerous, so we can do it for during the delivery, especially if it's a C-section. In menopause, we know that most, but not all of the fibroids will shrink with time after menopause. And we know that the use of hormonal therapy during menopause is not contraindicated whenever we have a myoma, so we can still give the hormonal therapy after menopause. And we know that this hormonal therapy will not induce new fibroids and new symptoms. So theoretically, what will happen that these same symptoms will continue because we are just giving more hormones to the fibroids. And definitely we have to be aware of risk of malignancy, because we know that the risk of mainly sarcoma, which is a tumor that looks like fibroids, is the menopause, is also the tamoxifen treatment, also radiation therapy, familial leiomyomatosis, and renal cancer. So whenever we have these ones, we have to be careful about sarcomas. Well, this is just to tell you thank you for your attention and thank you for coming here. And this was the Pavilion for Women when you came here, and I hope it will be like this when you leave home. Thank you.